Can everybody hear me?
Yeah, we can hear you.
Yeah, at the outset, I thank Dr. Gauri Shankar, Dr. Praveen, and the entire team of Senthil Multi Speciality Hospital for having invited me from all the way from Vijayawada for doing this workshop. And Gauri Shankar sir and I were in the same college doing MCH. He was my senior. Uh, Before I joined the college, he left, but he will be remembered as the most fondly, most fondly remembered PGs. Everybody used to keep talking about how affectionate he was with everybody. And that's how I know Dr. Gauri Shankar, and I couldn't say no when he called me for this workshop. So, meanwhile, the case is getting ready. Patient is getting draped. So, I just wanted to show you what all the equipment and what are the instruments I'm using for this procedure. I have been using this same instrument from the RZ company since the last 5 years. So this is a 22 French resectoscope. You can see this, this is a 22 French outer sheath, and it has a 19 French inner sheath. Unlike the regular 26 French resectoscopes which we use, and this is a working element which goes into this 19 French inner sheath, and we use this 2.9 mm lens which goes into this instrument. Unlike the 4 mm which goes through the 26 mm, this 22 French resectoscope has a 2.9 mm lens. And there's a laser guide which we call it, that's an extension laser guide through which the laser fiber goes in. So this is the equipment which we use for all our ThuFleps. This is also called a slim flep, which is coined by Dr. Filippi he's a Brazilian. And this is the morcelloscope which goes through the 22 French resectoscope. Previously, we are using the morcelloscopes by Storrs and Wolf. Now we have been using this 22 French RZ company morcelloscope, which goes through this 22 French resectoscope. So these instruments, I believe, would actually cause less strictures, and it helps in getting into the right planes when we are doing this anatomical enucleation of prostate. And the laser machine which we are using is an IPG 35 watt machine. This is the same machine which I have back in the hospital, and I've been using this since the last 7 years. And if you can see the setting, I use a Hertz 35 frequency, and 1 pulse energy is the setting which I use with a low pulse duration. So that is my regular setting for all my cases, be it the small prostates, large prostates. So, and if you look at the morcellator which I'm using, today I'm using a Tomy morcellator which has got a rotating blade. I normally use a Wolf Piranha morcellator, but this Tomy morcellator is very similar to the Wolf morcellator which I use, and it has a rotating blade which is very efficient, I feel. And the imaging system which I am using is Storrs Image 1 system, and yeah, so everything is ready. I'm just do a cystoscopy. If somebody can explain the case meanwhile. Yeah.
Hello. I'll tell a little bit about the case. A 71 years male who has history of infantile cerebral palsy.
This back.
Has IPSS score for 15. He went into acute urinary retention before 1 month. He was on catheter and gave medications. After 2 weeks, catheter removed, failed trial widening. Ultrasound wise, he is 72 cc prostate.
So something how to tie.
Now planned for
how to tie something.
Okay.
Gauze piece is there. Cut it. The OT lights off. Clean. Clean. Give the irrigation. Okay, laser fiber. Somebody can connect the irrigation. Outlet channel, please. Outlet channel. This can go a little up. Sure, you can, if this is loose, no, you can cut this and put it, okay? So this you can tie, gauze piece or something. Something.
Good morning, Dheeraj. This is Dr. Senthil Coimbatore.
Oh, enough. So I'll be starting this case. If you can see here, like the 26 French, if you use, we regularly use the otis urethrotom or the urethral dilatation before we start any laser enucleation or TRP. But the advantage of this 22 French resectoscope is that we can do the scopy directly. We can do the scopy directly with this 22 French resectoscope. Can we increase the light? Thank you. Sister, can I have the laser fiber, please? So as I am inspecting the prostate, you can see this is the verum montanum. This is the sphincter region. And we have grade 2 lateral lobes. And we have a long prostatic urethra. I believe the cystoscopy has already been done. The bladder was normal. So previously I used to use this 600 micron fiber, but of late I've been using this 365 laser fiber, which I feel gives a better energy delivery rather than the 600 fiber. So I'll be demonstrating an unblock technique with an early apical release for today's case, for this case. The approach for these cases should be like an open approach. When we start these cases as a beginner, we recommend everybody to start with taking out the median lobe and then the lateral lobes. That is the 3-lobe technique, and then slowly switch out to the 2-lobe technique. And finally, as we get more experience, we do more number of cases, we should be able to do the unblock technique, which I think is truly anatomical. So today I'll be demonstrating an anatomical enucleation of prostate, that is enucleation of the prostate by going in the right anatomical planes. I'll be highlighting my technique of early apical release, which I truly believe will help in maintaining the continence, which helps in giving the early continence after the procedure. The main drawback of doing enucleation rather than TRP is that there will be a lot of stress incontinence post the procedure. I'll be highlighting my technique in such a way how to prevent this stress incontinence after the procedure. Chair.
Good morning, Dr. Dheeraj. Can you hear us?
Yes, sir. Loud and clear.
Yeah. Okay.
Foot pedal, please.
Does this sheath have a beak?
Yes, sir. It has a big gap.
Do you use that to elevate the prostate, or is it purely using the laser fiber?
That's a very good question, sir. I'm a big fan of mechanical enucleation actually, because I started my enucleation process by using Thulium Fibre Laser, which requires a lot of mechanical effort rather than laser, unlike the holmium laser. So I'm a big fan of mechanical enucleation. But the unique property of this Thulium Fibre Laser is that it has a good dissecting property as well. So I use a little bit of laser energy and a little bit of mechanical energy wherever required, and that is how I combine both the energies to have a good dissection effect. So this is the verum montanum. I'll be demonstrating my early apical release technique. So what I'll do is, initially I'll mark the 12 o'clock incision. So this is the verum montanum. So I have marked my 12 o'clock, which will be a landmark and a guide for the rest of the procedure. You can see this already, the mucosa is little blanched here because of the catheter which is in place. And my idea is to preserve as much of ventral mucosa as possible, which is overlying the sphincter. This is a sphincter here, and I want to preserve as much mucosa as possible so as there will be good epitheliation of the striated sphincter fibers. Can the table go down, please? Once the 12 o'clock incision is taken, what I'm going to do is, I'm going to give a mucosal incision. If you can see, I'm giving a mucosal incision in a non-contact fashion. Yes, table can go down. Once I have given a decent incision, if you can see, I'll use this scope. I'll use the beak of my resector scope to develop this plane. If you can see here, this is the plane which I was talking about. This is only by mechanical energy, by use of a gentle mechanical blunt dissection, I was able to develop this plane. So this is the plane which is important. I developed this plane at this point because this is the area where the capsule is so thick. Just in front of the veru, this is the region where you can find the plane easily. Likewise, we give a mucosal incision on the opposite side as well. Just enough for the tip of the resectoscope, that is the beak of the resectoscope, to be admitted. So once that is done, we use the beak of the resectoscope just to gently push the prostate laterally and in an upwards fashion. You can see how nicely with just the beak of my resectoscope I have developed this plane. So as soon as I do that, I try to connect both the planes. This is the posterior plane here. This is the posterior plane here, and now I'll be connecting both the planes.
Dheeraj, when you do this, do you lose the anatomical the line to see the bladder neck?
Anatomical line to see the what, sir?
Bladder neck. Now when we elevate on all directions in this aspect,
Yes, sir.
will it be not difficult to go and see the bladder neck?
My approach will be to identify the bladder neck not in the posterior region, sir, but at the anterior region. I'll show it when I come across it.
Okay.
So this is the verumontanum. This is all the prostate which I was talking about. We developed a nice posterior plane here. This is the posterior plane which I was talking about. A lot of traditional surgeons would have already marked an incision here, but I exactly don't know how long the prostate will be extended beyond the verumontanum. So I give the incision a little bit later. That's the reason why I mark this 12 o'clock incision, so that I don't lose orientation. What I'll do is I will progress my dissection in an ascending fashion from the 6 o'clock to the 12 o'clock region, see how far I'll be able to take my mechanical dissection in an ascending fashion, and I'll try to define the prostatic apex more clearly towards the anterior aspect. When anybody learns prostatic enucleation, the most difficult step would be finding the anterior plane. Finding the posterior plane is easy, a lateral dissection is easy like this, but finding the anterior plane is the most difficult thing. If you can see here how nicely I am dissecting the tissue with the laser. Till now I have been doing the mechanical enucleation, but now I'm using more of laser. If you can see, even the 35 watts of energy in the non-contact mode has an excellent dissecting property, just like the holmium laser. You can see there's hardly any charring also.
Have you used a higher power with any other machine?
I don't see any reason why we have to use the higher power, especially in Thulium Fibre Laser. I think low power energy should be more than enough for us to achieve a good hemostatic effect. So this is the prostatic apex on the anterior side, if you can see. And that is... Okay. So this is the 12 o'clock incision, and if you can see, this is the mucosal wing. This is a mucosal wing which I have raised. The idea here of raising the mucosal wing is only after I get the prostatic anatomy, only when I define this prostatic apex on the anterior side, I'll be giving this mucosal incision so that I'll be able to preserve as much mucosa as possible. This is what I call the inverted V-shape incision. So this is the 12 o'clock, this is one limb of the V which are given, and the same process will be replicated on the opposite side as well. So the dissection would be carried out from the 6 o'clock to the 12 o'clock region. The most important things would be the hand movements here, if you are able to see in the PIP. I hope you are able to see the hand movements in the PIP. So only the initial part I'll be using the mechanical dissection, but most of the procedure I'll be using the very efficient dissecting property of this Thulium Fibre Laser to be able to dissect the gland. See, this is the mucosal wing which I have raised here on the patient's right lobe as well. And I go back to my initial landmark, that is the 12 o'clock region incision which I have given. And I give complete the extension of the V. This is the other limb of the V. And once the incision is complete, I will be deepening up this incision. So in this way, what I am doing is I am preserving as much mucosa as possible, and at the same time, I will be releasing the apical part of the gland, which has a close proximity to the striated sphincter fibers. I hope you can see the image well, and the voice is also clear.
Yeah, voice is clear.
Yeah. How about the image? Image is good?
Okay. The entire image is not seen. The lower part is cut off in the endoscopic image. That's okay. Otherwise, we can understand the procedure.
Okay, sir.
So the length of the fiber that you are keeping outside is very, very minimal. Is that the usual way you use? And do you use your finger to push it in and out, the fiber?
Yeah, now and then I push it outside and inside, sir, but this is my regular comfortable zone because I use little bit of mechanical dissection as well. So this would be my comfort zone.
And you would coagulate then and there?
Yes, sir.
You see a vessel.
I don't use any coagulation mode separately, sir. The same switch foot pedal which I use for cutting is the same pedal which I use for coagulation as well. So this, if you can see here, just for the orientation, this is the verumontanum, this is the prostatic lobe which is enucleated all the way from the 6 o'clock to the 12 o'clock position, and you can see that we entered a nice anterior plane here. So this would be repeated on the opposite side as well. The only thing which is attached to the adenoma is this part of the mucosa which is overlying the striated sphincter. So at the same time, I'm deepening up this mucosal incision. So everybody would be, there would be a lot of difficulty as to wherein we have to go to identify the anterior plane. If you keep on giving this incision, you might not end up in a right plane. You might go through the prostate, you might leave a lot of tissue, or you might keep cutting a lot of mucosa. So whatever incision you are able to give, you deepen it up a little bit. At the same time, you come opposite side where you already developed a plane. You can see that the prostatic adenoma is nicely enucleated by little mechanical dissection and laser energy. At the same time, you can see this mucosa, and from the opposite side as well, you know where is the plane. So this way also, you are able to separate the mucosa and also the gland, apical part of the gland which comes anteriorly. So it's not only going from the medial to the lateral, but you can come from laterally also and find your plane towards the anterior plane of dissection. Now, I believe this is the most important step wherein you don't cause much stretch on the sphincter. Now the idea would be to join both the planes. We have created an anterior plane here. At the same time, we have created an anterior plane from the opposite side as well. and it's a matter of joining both the planes is what is required now. Once an uniform plane is maintained, what we'll have to do is we'll have to go towards the bladder neck. If you can see here, this is the mucosa which I was talking about. It is completely free. This is the ventral mucosa sparing technique. The mucosa, ventral mucosa, which is overlying the striated sphincter complex, is completely separated. This is achieved by doing the mechanical dissection from below to above and finding a plane anteriorly. So now the entire anterior plane is created, and now normally what the traditional surgeons do is try to find the bladder neck from below, but I would prefer to find the bladder neck from above because I think that finding the bladder neck would be easier if we go from between the 11 o'clock and the 1 o'clock region where the bladder neck fibers are relatively thin. So now we'll try to take the dissection because the lobe is completely free. The apical part of the prostate is completely free. We are taking this prostatic dissection from the anterior plane towards the bladder neck. You can see here how nicely, only with the excellent dissecting property of the TFL, the prostatic adenoma is getting peeled off its capsule. A lot of people have the argument that thulium fiber actually causes a lot of charring and the planes would be very difficult to be produced. But I believe that it's not the laser energy, it's how we use the laser energy is more important. And if you are using this laser in a non-contact mode, you'll be able to have the same effect as this high power holmium laser energy provides. If you can see here, this is the anterior dissection which I have done from the apical part towards the bladder neck. Somebody was asking how to identify the bladder neck fibers. This is how we identify the bladder neck fibers. As we go towards the bladder neck, you can see the blood vessels are much bigger than what we came across. And this is the transparent circular muscle bladder neck fibers which we could appreciate. And once we cut it, we enter the bladder. So after doing this, it's all about the landmarks. The entire bladder neck will be open now, and we have a whole set of landmarks. Until now, we only had the adenoma, the capsule, as the landmarks. But once we open up the bladder neck, we get a whole set of landmarks. By using the bladder neck as a reference, we can assess to what depth we need to go on the plane of dissection posteriorly and laterally. And if you can see, this is only the 35 watt laser which we have been using, and I believe that we don't require high power lasers to do the enucleations. It's all about the anatomy, which is more important. It's all about entering the right planes. That is more important to produce a relatively avascular plane with good hemostasis. So I started off with doing a lot of vaporations in the beginning of the learning curve. I used to do a lot of vaporations, and slowly I started to enucleate the median lobe. And once I'm confident about enucleating the median lobe, and later converted to TRP, and I was doing a 3-lobe technique. And slowly, after realizing the importance of the planes, I've switched over completely to this anatomical enucleation with the unblock technique.
Dr. Dheeraj, we'd like to welcome Dr. Mallikarjuna. He has just arrived. He has a few questions.
Hello, sir. Good morning.
Morning, Dheeraj.
Morning, sir.
Wonderful dissection going on. I don't think I have any question there. Superb. I was just wondering whether you were using thulium or holmium. That was the whole thing when I was initially looking at. So this is how someone who does a good job and who has an idea about the lasers, that they can do all this procedure without any charring. And the most important thing, what you are doing for people to realize is you're not touching the tissue at all. You're probably about few millimeters away from the tissue so that the tissue falls off on its own. And then getting into the right plane is the most important thing, and the plane actually opens up. If you try to get into a plane, you will get into a problem.
Truly said, sir. I get the same question often. Most of the enucleation surgeons traditionally who have been using the thulium did not have this advantage of this dissecting property which the Thulium Fibre Laser had. So most of the thulium YAG laser who are using it had to do some mechanical dissection or use the contact mode to find the right planes, and they had to produce that charring effect which doesn't show the right planes like the holmium surgeons used to do. And because of the thulium laser, and because it's not a continuous wave, it's a pulsed wave with a very short pulse length as well, it is able to produce that effect. And the other advantage is in holmium, even the 35 watt machine, we tried doing these enucleations the same way, but the only problem is it does have the good dissection property, but it doesn't have as efficient hemostatic potential like that TFL laser has. So in a way, we can say that TFL has both the advantages of having a good dissection property of the holmium laser and also a good hemostatic potential of a thulium YAG laser. And like you rightly pointed out, it's how we use the energy. If it would matter, if we touch the tissue a lot, then it will char. If you can see here in the bladder neck, I actually have to touch the tissue to be able to cut the thick bladder neck or the fibrous component of the prostate. You can see a little charring which is being produced. Whereas in the other parts of the prostate, since it's a very glandular prostate, I don't have to actually touch it. I can just push it mechanically or use a little bit of laser energy in a non-contact fashion, which will help me just peel off the prostate off its capsule.
Yeah, but at some point of time, even in the prostate, you will have some fibers which will actually be tethered to the prostate. So those you may need to touch to cut. So without touching, it will not cut. That's the bottom line here. So it's nice to, but the bigger problem, if someone is using a 20 or a 30 watt holmium, they will lose some blast shields and they will have to get it repaired. So, but the 30 thulium fiber will still do the job without any issues. This is a workhorse.
Rightly said, sir. This client I've been lucky because I'm getting the planes very easily, but more often than not in the Indian population, like you know, there will be a lot of chronic prostatitis and we'll have to depend on the laser energy more rather than the mechanical enucleation, and we might need to dig into the prostate here and there to find the planes. And also this thulium, wherever there's charring, we can use it to good effect also. If we are lost in the planes, actually this charring, I believe, will help to come back to the right place. The advantage of this thulium is if you touch the prostate, it actually chars. Yeah. And you can actually find yourself your way back when you lose the planes also by using this charring effect is what I believe.
Correct. What you said, you touch the prostate, it chars. You touch the capsule, it doesn't char, it cuts.
Yes, as much, yes.
So that's definitely, but people should realize when you say that you are doing a mechanical dissection there, if they think that it is much easier to do this kind of mechanical dissection, they will be gone. Because they will easily go into the capsule, they'll perforate. And once you perforate, it is not easy to get back unless you have that experience of doing it. So the mechanical enucleation, what you say, looks very easy, saying that we can, take the scope and then start working around. But that has to be very, very carefully modulated hand movements. And I think people should see your hand movements. I think enough cutting you have done. So if someone can put in a PIP, Dr. Dheeraj's hand movements, so that's, you see how small the movements are. If you actually push it very hard, you will get into the capsule. You will easily perforate. It's not difficult to perforate at this point of time. So people should realize that it's a very, very small movements and very calibrated movements which are important there.
Yes, sir. Everything is about landmarks in this enucleation. I just wanted to come back and show orientation to everybody.
Yep.
This is the verumontanum. So this is the ventral mucosa which we have preserved, and because of the previous catheter we already know that the urethra is blanched. Now I feel I have not caused much harm because of this 22 French resectoscope. You can see the complete apex has been liberated from the striated sphincter complex and also the ventral mucosa which we have preserved. We opened up the entire bladder neck, and the lateral dissection on both the sides is complete. So only thing which is remaining attached is the posterior aspect of the prostate, which I am going to dissect now. And as I was talking about the landmarks, if you can see, this is the capsule, this is the prostate. People should not blindly dissect this gland without knowing to which part they have to go. If they go here, it will be too deep into the capsule. If they go here, it will be into the prostate, leaving behind tissue. So this bladder neck is used as a reference. If you can see here, this is the bladder neck.
Yep.
And you can see this bladder neck is, the capsule here near the bladder neck is usually thin, and this is where we tend to perforate a lot, and we should use this bladder neck as a reference to be able to dissect select your plane of dissection. It is okay to leave a little bit of prostate tissue here because it tends to be very sticky at this area, just distal to the bladder neck, and you should find your right planes by seeing the bladder neck all the time.
It's nice sweeping movements of the bladder neck which actually take the prostate away.
Yeah.
The second thing is, if you have to err towards the prostate, please do not err away from the prostate. Because you have always a second option to take if there is a residual little lobe around that, you can always cut it and take it away. But if you go into the capsule, then you will open up a whole new plane and then you go somewhere else.
Correct. So what sir was telling is about this articulating movements, work in small areas rather than large areas to maintain the orientation. So if you are doing this part of dissection from here to this side, you lose all the orientation. So since you have a landmark here, work in small areas. Work in small areas so that the orientation will not be lost, and you will find the planes very easily. So since I have this landmark, I am working here more. So easily you are not losing the orientation when you are working in a very articulated manner and using small movements.
Sir, do you think that slim ThuFlep will have any role on incontinence?
Yeah, definitely, because everybody keeps talking only about the amount of stricture prevention it can do, but I truly believe to be able to enter these narrow spaces, I truly believe that slim ThuFlep has helped me a great deal.
Because there are a few papers coming up saying like slim ThuFlep has got a better role in continence mechanism than a regular ThuFlep. So
definitely. When we are doing all these movements, articulate movements, and when we are trying to enter all this, I've been working all around the prostate, if you can see, and what a 26 French would have caused is a lot of shearing on the ventral mucosa, and it would have caused some kind of necrotic effect or a deepitheliation on the sphincter muscle fibers. These are all the sphincter fibers, and if you can see, this is mucosa which is very nicely preserved. I think it is only because of the 22 French we are getting this effect. If it was a 26 French, when we are working in such narrow spaces, there will be a lot of shearing on the sphincter fibers, which will produce a little incontinence after the procedure. Yeah.
Agreed, sir.
So always the patient's right lobe will be a little tougher than the patient's left lobe, because we are all, most of us are right-handers, and this is the backhand for us. So always I try to tend to do more dissection towards the patient's left lobe than the right lobe. This is the area which I was telling. This is the area where most of the perforations do tend to happen. Now the idea would be to join both the planes posteriorly. So we completed the lateral dissection, anterior dissection, completely released the apical part. Now the challenge is to actually join the planes on the posterior aspect from both the sides.
How are you able to identify the bladder neck on the posterior aspect?
Bladder neck I have opened up now,
Already
sir. So
there.
yeah, everything is opened up, bladder neck. So once I enter the bladder neck at the between the
all around.
Yeah, when I enter the bladder neck at the 12 o'clock region, I take the bladder neck down from both the
Okay.
sides. So once completely bladder neck is taken down, that will be my reference point for the rest of the dissection as to what depth I need to do my further, how to, dissection.
Okay.
So this will be a tough part also initially because all the gland I have taken it down from above, and there will be this lateral lobe, there will be the median lobe, and also we'll have to connect to the other lobe also. So there will be literally 3 planes which I'll have to manage. Some prostates, they don't have a wide base, but this prostate is having a little bit wide base, so I need to figure out how to join all the planes slowly. So if the good thing about en bloc technique is that if you lost a plane on one side, you can come back from the opposite side. Like I said, in the patient's left lobe, I found a very good plane, so I'm progressing my dissection, but it was not the case when I was dissecting from the opposite side. So I'm actually taking the dissection towards the patient's right side, so it will be easier for me later in the later part. If we lose a plane somewhere, we can always come back from the opposite side and find our cells a good plane. So there is a medial lobe as well, which is very deep, and it was already discussed, it's okay to leave a little bit of prostate wherever necessary. So this is the plane which I couldn't find decently earlier, and I had to come from the opposite side. You can see this is the plane on the patient's left lobe, this is the plane on the patient's right lobe. Now I can see everything clearly. Now it's only a very narrow strip which is left behind.
If there's a large median lobe, would you cause a lot of subtrigonal dissection, and how would you prevent that?
Yeah, this is the same thing which I was explaining, sir. Whatever it is, I've been doing the en bloc dissection since so many years, and the challenge is that if you have a big median lobe, so the base would have been even wider than this. So my this thing will be always about landmarks. My dissection would be from above downwards, and lateral to medial is what I follow. So I've taken the bladder neck from above downwards, and also all the gland from above downwards. And at the same time, from lateral to medial is what I dissect, and try to leave as much narrow strip as possible. If you can see here, this is a very narrow strip which is left. And I turn this side, I see the bladder neck, and turn this side also, I see the bladder neck. So I know to what level I have to dissect. So if I go here, it will be too deep. If I go here, it will be, it is safe. It's okay if we, as a beginner, you can actually take the plane of dissection from here. But as we are more experienced, we tend to take as much of prostate as possible at this point of time.
Wonderful, very good dissection, Dheeraj. We have appreciated all the anatomical landmarks. Very good.
Yeah, thank you, sir. Thank you. So it's I truly believe enucleation is about landmarks. So that's why we call this the AEP, Anatomical Enucleation. Previously, we were using a lot of laser energy to create a good cavity, but we tend to leave a lot of prostatic tissue behind, which causes a lot of dysuria or even bleeding sometimes. But if you are in the light planes, you don't tend to leave much of the prostate, and you are in a better situation to achieve adequate hemostasis as well. Yeah. So if you could have noticed, I have not used any specific hemostatic setting as well. The same setting which I used to use, which I used for the cutting effect, is what I am using for the hemostasis as well. Just defocus. We do the non-contact mode for achieving the hemostasis as well. Yeah. So if you can see, this is the entire prostate removed en bloc. So this is the apical part of the prostate, and if you can see, that is the median lobe. A little bit of median lobe is there. And if you can see, because everything is in non-contact mode, you hardly saw any charring. If it would have actually touched the tissue, it would have been like this. It would have been more yellow, but it is very smooth, and everything is done in a non-contact mode. A little bit of mechanical enucleation has been done.
So what will be your pre-op counseling regarding stress urinary incontinence for these patients?
It varied across my learning curve, sir. Right now, I tell my patients it will be about 15% for the first 15 days, which would settle down, and maybe less than 5% would have the same, very minimal incontinence. At the most, would have to use one pad per day for about 3 months, maybe. There are very few patients who had stress incontinence beyond 3 months as of now, and whoever have had it, it was only a few drops, and they were of very older age group, or they were diabetic, or had some neurological issues with them. But otherwise, for an index patient, right now my counseling would be 15% for the first 15 days maybe, and very few people would to have incontinence for about 3 months. But thorough counseling is what is important. My incontinence rates were really high when I started this enucleation. We had to stop the program for a lot of days because we were really panicked. And everybody has to go through that phase of learning curve where there will be a lot of stress incontinence. And thorough counseling is what is required.
Sir, does that N block and 3 block technique does have any role in incontinence mechanism, or like just the time duration gets saved?
It has several advantages. All the advantages which you actually told, that is the time, it is very quick. I think this is something which is very reproducible. It is about only finding the right planes. Instead of giving multiple incision, one incision you give in front of the verum montanum, we are in the right plane. So I think that is one thing. And the other advantage it gives me is we are doing the ventral mucosa sparing and the early apical release, which we can't do when we do the 3-lobe technique. So my results have really improved because of using the ThuFlep, and also because I have done this early apical release. Only after I started doing this early apical release, I started to have better continence rates when we look at the results rather than doing the 3-lobe technique.
So I think the incontinence is not mainly due to the damage of the sphincter. I think it's more of the thermal effect when you are cutting. So that is the one which damages the sphincter, I suppose. I'm not sure.
A lot of holmium laser people use the high power lasers,
Yeah.
sir. I'm not sure it causes much effect. But only thing I can say about the power of the machine is that I used to have a lot of bladder neck contractures when I was using the Thulium YAG laser, especially at the bladder neck. But I don't think it will cause much of an effect in the near the sphincter region, is what I believe. It's more of the mechanical stretching, or whenever we do this enucleation, there will be a lot of sphincter fibers which are attached to the apical part of the gland, which are actually
Get stretched, yes,
yeah, get stretched, and that is what causes the incontinence, is what I believe. But I think it has a little role in the bladder neck contractures, is what, from my personal experience, maybe it was because I used it in the initial phase, I don't know. But there are no papers as such that we use high power lasers and we have more incontinence or bladder neck contractures. But what I really believe is that even with the advent of this TFL, people who already have a 35-watt laser can actually start doing enucleations also. It's not only for the stones, is what I believe. But when I have to recommend somebody to buy a laser, I think they have to buy a 60-watt, because if at all, it's not easy to find all these nice planes initially. We get lost in the planes, and high energy actually helps in at least completion of the cases by cutting through the prostate. It takes lesser time for a 60-watt laser machine than a 35-watt laser machine to actually cut through the prostate and find yourself a plane and get out of the procedure in case of a bleeding. So I would recommend for a beginner, if somebody is really considering a prostate enucleation program, but if already they have a 35-watt machine or a previous holmium or a Thulium YAG laser enucleation surgeon, 35 watt should be enough, is what is my message.
Would that cause more charring, or is just the contact and non-contact?
No, sir. Whatever I did was with the 35, and I think that is more than enough if you want to do a good enucleation. I don't think it offers much of an advantage. I think it's more. I really believe it's more about the planes rather than anything. Even 20 watts of energy would produce a good hemostasis. What else we want? You have seen that 35 watt also is creating nice planes in a very decent pace. This is a 80-gram prostate, I think, which according to the ultrasound, and we finished it in a very good time. I use the same laser for all my prostates. The highest I have done was about 300-gram prostate also, which took about 1.5 hours time. And all my big prostate also use the same laser. I don't see any reason why I have to use a higher watt machine. But definitely, I have to admit, I learned my enucleation from a 200-watt Thulium Fibre Laser, which made me thorough with my anatomy. I was able to complete the procedures even if I lose the planes. Mr. Morcellation. So in the beginning, in the learning curve, yes, definitely the higher power laser actually helps. Morcelloscope system.
It's nice to see that you have spent quite a significant amount of time for the hemostasis.
Yes, sir. We should do that always, sir.
Yeah, good, very nice. Would you consider using a bipolar for just doing the hemostasis?
Frankly, I never had to use it, sir.
But
In the beginning stages, yes, it should be there as a standby. Yeah, morcellation, especially when we start all these enucleation cases, it takes a lot of time. Now this has been completed in very less time, but when I started this enucleation technique, I used to take 3-4 hours in the beginning, and by the time for the morcellation, we are already tired, and the staff are tired, the OT, everybody is tired. They tend to forget to keep the irrigation running, and we are also tired, exhausted mentally. And that is the time when we used to cause some bladder perforations because of poor hemostasis. So hemostasis is very essential for preventing any morcellation related complications.
Okay. And this sheath accepts both the resectoscope and morcellator.
Remove this system. Yeah, sorry sir, I didn't get you.
The same sheath is used for both the resectoscope and morcellator.
Correct, sir. This 22 French outer sheath admits this morcelloscope as well.
Okay.
And if you can see, we have just removed blade. If you can see, what I have done was I have just removed the working element, and I have just passed my morcelloscope. So
yeah,
always
appreciate that.
Yeah. Always a morcelloscope has 2 working channels, and we should switch off the. If you can see here, we should switch off the outlet.
Continuous irrigation.
Outlet, the inlet will be there, and we should also use the other inlet for continuous irrigation. Can I have another IV set or a
So it's
IV set is ready?
at the same time?
So 2 irrigation sets is what is required continuously, and the sisters have to be alert that the irrigation flow is going on. This is a 2-me morcellator which I am using.
Sir, and we have seen like ultrasound being used for real-time visualization. Do you have any experience? Like, do you feel it is necessary or like not needed?
Sir, if you can notice here, the amount of vision, the what all vision you could see from a regular 2.9 mm telescope. Sister, switch it on.
We can't see the endoscopic image.
Because the working channel is very big and optical channel is very small. So you can see here the vision is not great, and always having all these extra things would be helpful. I just put an ultrasound just to show you how it works, and I will start the morcellation and somebody can show the ultrasound as well. This is a Tomy morcellator which I am using, which has a single foot pedal, and a soft press would be, if you can see here, I'll do the soft press here. It will actually suck the tissue into the blade. Just catch hold of it, and if you press the foot pedal, it will be rotating and at the same time morcellating the tissue as well.
You seem to be doing it at one go, or do you stop and go several times?
At the same time, sir, we don't need to stop or anything. I just wanted to demonstrate a certain point. If somebody can show the ultrasound also. In this case, it's not required, but somebody asked me about why we need an ultrasound. For that, I'll say that in the beginning stages, you will not have such good hemostasis. That is one thing. And you can say that some of the prostates, there will be some compensated bladders, low capacity bladders, wherein the bladder tends to empty very quickly. So those are the cases where ultrasound really comes in handy. So those are the two advantages. I'll talk about another advantages in a while. It's the catheter right in fetch 3 way. So all rotating morcellators are efficient. Previously there were only few. I regularly use a Wolf Piranha morcellator, which is very similar to this. It has a rotating blade, and there was morcellators from Stores and Luminous, which are not rotating, and they were moving forward and backward, which fell out of, which are not used much as of now, because they are not as efficient and as fast as these rotating morcellators.
So actually this to me is a pretty good version of the morcellator, latest morcellator available, I feel, sir.
Correct, sir.
Yes, sir.
Don't switch on the ultrasound. I'll show another point. One minute. So this is the last piece of the prostate which I have removed. You can see, appreciate the nice cavity here. And one more thing about this ultrasound system, give me the catheter. Catheter, please. So the ultrasound also helps us that there are no residual lobes which in the bladder also. And if you can see in the ultrasound, whenever we do these large enucleations, as you have seen, we have opened up the entire bladder neck. I'll give you a practical problem wherein we do a 100 gram prostate and 80 gram prostate. We inflate the Foley's balloon only to about 40 ml, and it's not enough. We give a little traction, the whole balloon would come into the prostatic fossa, and we are not able to secure the bleeders which come from the bladder neck.
But I think even in TURP, when you do a complete resection, the same problem occurs. I think it has to be at least 60 ml.
This load. More? Yes, sir. So this prostatic enucleation we are doing for much larger glands. So sometimes I need to give even about 100 cc's in the Foley's balloon so as to secure the bulb inside the bladder. This is a practical point which I wanted to tell, and we can see like this whether the balloon, if you can see in the ultrasound, we can see the balloon fits in the bladder neck or it is coming into the prostatic fossa. It's always a point which routine which I follow in our OT. Yeah. Thank you. Those are the advantages of the ultrasound.
Very nicely demonstrated. Thank you, sir.
Thank you, sir.
And like post-operatively, you continue irrigation, you don't continue irrigation. What is your protocol?
Yeah, whatever irrigation is already there in the OT, I tell our OT staff to continue the same things. If you can see here, the irrigation which is left, we use the same things for irrigating, and it will depend on how much of color is there. Usually our post-operative team would take care of it, because sometimes we might need to operate patients on aspirin or a clopidogrel if required, and these are the patients where we might need to give a little irrigation as well. It depends on the color of the outflow. Maybe for this case it might be required for about 2-3 hours, and we should be good with it.
When do you restart your antiplatelets, like anticoagulants, like?
If required, we never stop the antiplatelets. Aspirin, we do all our patients on aspirin if required, and if at all we stop them, we give them the next day. So clopidogrel will start after 5 days. Aspirin will be given the same day or the next day. If required, we don't stop aspirin altogether.
Thank you, sir.
Thank you.
When do you remove your catheter?
Catheter, that's a good question, sir, because it varies from patient to patient. It depends on what the caliber of the urethra is rather than what size of the prostate I am doing. If it is a very good caliber urethra and the mucosa is not blanched at all, we generally remove in 36 hours. If I do the procedure in today's evening, day after tomorrow morning, we'll remove them. If I do it today morning, early morning, if I remove it tomorrow evening. So that is for an index case. If the urethra is tight I tend to leave the catheter for a longer time, like 72 hours. Maybe I'll ask the patient to go and come back after 5 days. So I depend upon the caliber of the urethra. I just want the mucosa to heal nicely rather than depend on the size of the prostate. If the patient is on antiplatelets, maybe I'll leave the catheter for a longer time.
And what sizes Foley's you use?
I use 18 French 3-way, sir. If at all I feel there will be little bleeding postoperatively, I might use a 23-way. And then again, it also depends on the caliber of the urethra. Yeah. Here, the caliber of the urethra is little less, so I had to use a 18 French 3-way. There is a submeatal narrowing, and also there is some mucosal blanching towards the proximal bulbar urethra, so I only put a 18 French 3-way, which is what I normally do. If I suspect any blocks postoperatively is when I use a 20 French 3-way.
The problem with the 18 French, sometimes the bulb doesn't hold 100 cc.
Yeah,
sometimes that's